Let's start this lecture on fluid and electrolyte balance. I'm Saman, Dr. Saman Nanayakar, Senior Lecturer in Anesthesiology, attached to University of Peradeniya. So during this lecture, we should now look at the distribution of water within the body. So I earlier said in an average built adult, there's about 60% of the body, 60% of the body weight is water. So if you take an adult who is 70 kilograms body weight, 60% of 70 kilogram is 42 kilograms. So you have 42 kilograms of water in an adult human. Since density of water is 1, this 42 kilograms would be 42 liters if you consider the amount of water in a body as a volume. So an average built adult has 42 liters of water in the body. Now this water how is this water distributed within the body? So we have different fluid compartments. We have ICF, intracellular fluid compartment, and we have extracellular fluid compartment, the two main compartments. When you look at ICF, so out of this 42 liters, two-thirds of it, or 66% of this total body water, is inside intracellular fluid. So that would amount to about 28 liters. And the rest of the 33% or one third of total body water is in the extracellular fluid. Out of that, which is about 20% of the body water, 5% will be intravascular and 15% will be in the interstitial fluid, the fluid compartment in between cells. So finally, you have about 3.5 liters of water in the intravascular compartment and 10.5 liters of fluid in the interstitial compartment. So in the intravascular compartment, you have about 3.5 liters of water. This plus cells will make the total blood volume about 5 liters. So here also, if you look at this diagram, you will see 40% of the body weight or 66% of body water is in the intracellular fluid compartment, which is about 25 to 28 liters. Well, different references, different books would give different values. All what you need to do is to try and get the big picture into your mind. And then, so this is two-thirds of water amount, and this is one third or 33%. Out of that one third, which is about 20% of the body water, a small amount is in the intravascular compartment as plasma volume, rest is in the interstitial fluid in between cells. Right, so this chart is to show again something we discussed earlier. So if you look close, you will see in a premature infant, total body water as a percentage of the body weight is about 80%. In a full-term neonate, it may be again 80% to 75%. When the child grows to 1 month to 1 year, it will drop to about 65%. In a 1 to 12-year-old, it will be again 60%. So in an adult and in adolescents, when in the males, it will be about 60%, whereas in females, water as a percentage of the body weight would be 55%. However, when you look at the distribution of fluid in between the extracellular fluid compartment and the intracellular fluid compartment, we discussed earlier that in adults, a higher percentage of water is in the intracellular fluid compartment, whereas in neonates, infants, and children, a higher percentage of water is in the extracellular fluid compartment. Right, a few more words about fluid and electrolytes in different body fluid compartments. Now, when you look at the intravenous fluid compartment, so the proportions of intravenous fluids, how much of intravenous fluid is going to be there in a body is influenced by the amount of osmotically active proteins in the blood. Then when you look at the interstitial fluids, the fluid that is around cells, so it's a type of extracellular fluid, it can accept or donate water and electrolytes to the intravascular compartment or to the intracellular compartment. So depending on the osmolality and depending on the degree of dehydration or hydration in different compartments of fluids, this will happen. Then when you look at the composition of body fluids contain electrolytes like sodium, potassium, chloride, and non-electrolytes like glucose and urea. So now look at this chart to see uh, the differences in electrolyte composition between intracellular fluid and extracellular fluids. Now certain ions, so electrolytes are more in extracellular fluid like sodium, which has 142 in extracellular fluid versus 9 in intracellular fluid. Then chloride at the bottom, you can see again more in extracellular fluid. And there are certain ions, so electrolytes, which are more in the intracellular fluid, like potassium. There's a high amount of potassium intracellularly, 150 versus 4 in extracellular fluids. Then again, magnesium, more in intracellular fluids, less in extracellular fluids. Then sulfates, phosphates, and proteins also, high amounts in intracellular fluid and less amounts in extracellular fluid. Okay, now we will look at different intravenous fluids or IV fluids. So there are many intravenous fluids, IV fluids, many types. So they vary in electrolyte composition, vary in osmolality and colloid osmotic pressure. And so all those things of IV fluids can be divided broadly into two categories: crystalloid IV fluids and colloid IV fluids. So what are crystalloids? Crystalloids are where you have electrolytes dissolved in water. So they can be further subdivided into isotonic, hypotonic, and hypertonic crystalloids. Isotonic crystalloids, hypotonic crystalloids, and hypertonic crystalloids. We will be learning about those things in the next few slides to come. And colloid intravenous solutions can be divided further. So what are colloid intravenous solutions? Those are solutions where you have large molecular weight substances in water. So they can be subdivided further into natural and synthetic colloids. Examples for natural colloid solutions are blood and blood products like fresh frozen plasma, platelets, cryoprecipitates, and things like that. So we'll first go through crystalloids. Now, uh, all intravenous fluids can be divided into two large groups: crystalloids and colloids. So, crystalloids are largely solutions of water with various electrolytes dissolved in that, and colloids are again largely water with osmotically active particles in the solution. So, let's look at crystalloids first. So, in crystalloids, sodium is the main component, like in the extracellular fluid, and they are suitable for replacing extracellular fluid losses. For an example, gastrointestinal losses like a diarrhea or vomiting, crystalloids are good. Then, even in a hemorrhage, a patient who has bled, crystalloids are good, at least to start with, and crystalloids are good enough for a minor bleeding. So, their effect generally is very short lasting in the intravascular compartment. So they would last, crystalloid intravenous solutions would last in the intravascular compartment only for a very short period of time. Now, when you look at the tonicity of a crystalloid solution, or osmolality of a solution, again we can subdivide them into three main groups depending on the osmolality or the tonicity of the crystalloid solution in relation to the serum osmolality. So thereby we can see three groups: isotonic crystalloids, hypertonic crystalloids, and hypotonic crystalloids. So isotonic crystalloids, their tonicity is equal to the tonicity of extracellular fluids, serum. An example for that is normal saline or Ringer's lactate or Hartmann solution. Then we have hypertonic solutions, the tonicity of which is higher than that of serum. Examples are hypertonic saline, mannitol, and sodium bicarbonate solutions. Then there are crystalloid solutions which are hypotonic, which means their tonicity is less than that of serum. Their examples are 5% dextrose and 0.45% saline with dextrose or 0.18% saline. Right, so isotonic crystalloids, so their osmolality or tonicity is equal to that of the body fluids and they are freely permeable to vascular membrane. So if you infuse an isotonic crystalloid into the intravascular compartment through a cannula to a vein, they can go through the vascular membrane freely. So they distributes through the plasma and interstitial fluid, and they will find it difficult to move into or out of cells. So after an infusion of an isotonic crystalloid, only about 25 to 30% will remain in the intravascular compartment. Rest will enter the interstitial space. And so if there's excess amount of isotonic crystalloids collecting in the interstitial space, that would be seen as edema. It could be peripheral edema or pulmonary edema. Okay, further discussions about isotonic crystalloids. So, as I mentioned earlier, examples are normal saline or 0.9% saline and Ringer's lactate or Hartmann solutions. So, what are the special advantages of isotonic crystalloids? So, one thing is they are quite cheap and freely available. You go to any ward, normal saline is available, and they have basically no allergic effects and no toxic effects. And when you infuse normal saline or Ringer's lactate, they will initially be in the intravascular compartment, then they will spill over to the interstitial space, and thereby isotonic crystalloids can be used to replenish interstitial space. So, what are the disadvantages then? So, as I mentioned earlier, isotonic crystalloids are not very effective to replenish the intravascular volume. Why? You can insert a cannula and infuse isotonic crystalloids into the intravascular compartment. However, after a while, those fluids will diffuse through the vascular membrane into the extracellular volume, namely initially to interstitial space. So they can cause interstitial edema, which could be peripheral edema or pulmonary edema if you infuse a lot of isotonic crystalloids. So you have to be very careful when you infuse isotonic crystalloids to kids, neonates, or infants, or children, and elderly and critically ill patients. If since their vascular endothelia are not as strong as in an otherwise healthy person, they can easily diffuse into interstitial space and cause interstitial edema, like pulmonary edema or peripheral edema. So, if you infuse a lot of crystalloids to a child or an elderly, the patient can even die due to pulmonary edema. Next is these isotonic crystalloids, so they are largely water with electrolytes. So, they will dilute other constituents in plasma. For example, they will dilute albumin. So the albumin concentration would drop, reducing the oncotic pressure. And they will dilute coagulation factors, leading to a coagulopathy. Right, so normal saline or 0.9 saline is an example for isotonic crystalloids, and it has 9 grams of sodium chloride per liter, and it has sodium ions 154 millimoles per liter, and equal amount of chloride 100 54 millimoles per liter. So normal saline is better than Ringer's lactate when it comes to replenishing fluid losses after vomiting, because normal saline has more chloride, and in vomiting patients tend to lose more chloride. Ringer's lactate and Hartmann's solutions, so they are also uh, isotonic crystallite solutions, and they are sort of more balanced electrolyte solutions because they have some more extra electrolytes. Now normal saline has only water, sodium and chloride, whereas Ringer's lactate has sodium chloride and some potassium, calcium and lactates. This lactate would get metabolized into bicarbonate in the liver, and Ringer's lactate solution is considered more physiological than 0.9% saline or normal saline because contents are relatively closer to plasma when compared with normal saline. Now let us see a few examples for hypotonic crystalloids. The tonicity of these crystalloid solutions are less than that of serum. So examples are 5% dextrose or, and 0.45% saline, and which is also called half normal saline, and also 0.18% saline, or which is one fifth normal saline. Uh, so, for an example, if you consider 0.45% saline or half normal saline, why do we call it half normal saline? Normal saline is 0.9%, so this is 0.45, which is half of that. So, when infused, since it is hypotonic, it will decrease the extracellular fluid osmolality, and therefore water can move into intracellular fluid which has a higher concentration, higher osmolality. Let's see what 5% dextrose is. So initially it may behave like an isotonic solution at the time of infusion, but very soon dextrose would get metabolized and leaving behind only water, and water alone is hypotonic compared with serum. So then this solution would get distributed in the body fluid compartments according to body's natural law of distribution of water. So 66% of what you have infused as 5% dextrose would go to the intracellular fluid compartment, and 33% would go into the extracellular fluid compartment till osmolarity equals. So what are the disadvantages with 5% dextrose? So they can cause cellular edema because there's a chance for a high amount of 5% dextrose to enter cells. And serum sodium concentration decreases because there's no sodium in 5% dextrose. And there are no electrolytes. That is also a disadvantage. So this is only dextrose and water. And it doesn't expand the intravascular volume. So therefore, in a patient who has bled or who has had hemorrhage, especially if it is a large hemorrhage, massive hemorrhage, 5% dextrose is of extremely minimal use. So don't infuse 5% dextrose at the beginning because it would not stay in the intravascular compartment to expand the intravascular compartment, but it would easily move out from the intravascular compartment into the extracellular fluid, and from there into the intracellular fluids. However, in a severe hemorrhagic patient who has bled so much, finally there's dehydration, not only in the intravascular compartment, but there will be fluid being drawn into the intravascular compartment from interstitial compartment. And when the interstitial compartment also dries out, there will be water being drawn from intracellular compartment into the interstitial compartment, and from there into the intravascular compartment. So water will move from cells to interstitial compartment to intravascular compartment or into inside blood vessels when there's a lot of hemorrhages happen and when the patient is very hypovolemic, very dehydrated. In a situation like that, if you have transfused blood and if you have infused synthetic colloids to fill the intravascular compartment, And later, to compensate for some losses that took place from the intracellular compartment, maybe you can infuse 5% dextrose, because some of it can enter the intracellular compartment and replenish the intracellular compartment also. But that's not the first thing to be given in a patient who is bleeding during surgery or after surgery. 5% dextrose is not the first solution to be given. It has a minimum use in hemorrhage. So, what are examples for hypertonic crystalloids? So, we have hypertonic saline, which could be 7.5% saline or 3% saline. We have mannitol, we have sodium bicarbonate. So, look at 7.5% saline. So, it is good for small volume resuscitation. Now, for instance, you can give 4 milliliters per kilogram within about 2 to 5 minutes via a peripheral vein. So, you can give a small volume and resuscitate the patient's volume loss. Because this is so concentrated, this will draw water from the interstitial compartment into the intravascular compartment. So you give a small volume of hypertonic saline into the intravascular compartment, it will draw water from the interstitial fluid. So it is useful in severe hypovolemia, like in trauma or hemorrhage. It will reduce the edema formation. The opposite of what happens with 5% dextrose will happen here. So it has a very high osmolality, 2400 milliosmoles per liter. So it can mobilize fluid from extracellular fluid or interstitial fluid into the intravascular compartment. So 3% saline is another example. Sometimes you will see 3% saline being used on hyponatremic patients also. You may give about 100 to 150 milliliters over 2 hours maybe. Right, so I told at the beginning, all intravenous fluids can be divided into two main groups, crystalloids and colloids. I told crystalloids are largely uh, electrolytes in water, and in colloids you have water, and dissolved in this water you find osmotically active, relatively large molecules. And we also mentioned examples for crystalloids. So then we talked about isotonic crystalloid, hypotonic crystalloid, and hypertonic crystalloids. So now we'll talk about colloids. And so colloids contain solutes with high molecular weights, and therefore colloid solutions do not cross capillary membrane easily. Why? They have high molecular weight substances in the solution. So because of this high large molecular weight molecules in this solution, once infused into plasma through a cannula, it will increase the plasma osmotic pressure, and therefore it will draw water from intracellular fluid into the vascular compartment. It will draw first from the intracellular compartment to the interstitial compartment and then to the intravascular compartment. And colloids have a longer half-life in plasma, maybe through 3 to 6 hours. We earlier told crystalloids have a relatively short half-life in plasma because crystalloids would leave vascular compartment. Although we are infusing it into the vascular compartment through a cannula, it will leave the intravascular compartment. A larger percentage of the crystalloids would leave the intravascular compartment and enter the interstitial compartment. And colloids are effective plasma volume expanders. So what do you mean by that? So if you infuse a colloid solution into the intravascular compartment, it will remain in the intravascular compartment for a relatively longer period of time, and therefore the colloid itself will expand the intravascular compartment. So it's a volume expander, and at the same time, since it contains these high molecular weight molecules, it will increase the oncotic pressure of colloid, and thereby it will draw water from the extracellular compartment into the intravascular compartment. Right. So when it comes to infusing colloids To replace a blood loss, you can transfuse or you can infuse colloids at a ratio of 1 to 1. So if the patient has bled 1 pint of blood, you can give 1 pint of a colloid. If the patient has lost 2 pints of blood, you can give 2 pints of colloids to replace the blood loss. Well, you are replacing the volume here. You know, in addition to the volume, blood contains other very, very important things like red blood cells, white blood cells, platelets, and many other things. But when you consider the blood volume, if you want to replace only the volume, which is enough. So for example, in an otherwise healthy person, relatively uh, young or middle-aged, otherwise healthy person, if he has lost blood, you don't have to transfuse him blood all the time. Especially considering the complications of blood transfusion, you can manage by giving only a synthetic colloid, right? So in a situation like that, if you want to replace the blood loss with a colloid solution, then comes the question of how much of colloid should be infused to this patient. So for a mild to moderate blood loss, you may use only synthetic colloids without using blood, and there you can infuse the volume 1 to 1. So if the patient has lost 500 milliliters or 750 milliliters of blood, you can infuse 500 or 750 milliliters of a synthetic colloid, and you get a similar vascular expansion effect. But still, blood components like red cells and white cells and platelets are missing. That is true. Right. So, what are the special advantages with colloids? So, they are used for volume resuscitation. So, resuscitation of the intravascular volume, like in trauma, hemorrhage, and they are useful for fluid resuscitation in the presence of hypoalbuminemia. So, we know with hypoalbuminemia, oncotic pressure of serum is less because albumin is responsible for maintaining oncotic pressure or osmotic pressure. So in a situation like that, colloids are useful. And also colloids are useful in situations where there has been a large protein loss, like in burns situation. So in burns patients, you will see they don't have the skin covering, therefore plasma is oozing out all the time. Dressings are also wet. So the patient is losing water and proteins. Now colloids do have some proteins, whether it is hydroxyl, lots of colloids have proteins. So if you infuse a colloid solution with proteins like a gelatin solution, it is good as replacement of part of the protein loss. So what are the disadvantages of colloids? So they are expensive and they are not freely available. So they will not be freely available in all wards. So colloid solutions can cause a coagulopathy, especially dextran solutions, starches. And once infused into a person, and thereafter, let's say you want to cross match blood for this patient for a later blood transfusion, now you draw a sample of blood from this patient to whom colloids have been infused earlier, and now you send it to the blood bank and try to cross match blood for this patient from another person. There can be issues with cross matching. And so cross match is when you want to transfuse blood to a patient, you take a sample of blood from that patient who needs a blood transfusion, and then you take a sample from the possible donor's blood sample, and you try to see whether the two match after transfusion. Otherwise, there can be allergic reactions. Then, so these colloids can reduce ionized calcium because solutions which have albumin can bind to calcium. And some of these colloids can cause hypersensitivity reactions, allergic reactions, can cause even anaphylaxis. So when you are resuscitating a person with colloids, better to check whether they have had any allergic reactions to intravenous fluids before this. If the patient says yes, it may have been to a colloid solution. And also when you resuscitate a person who is after an allergic reaction for something else, let's say for a particular drug, if he is in a moderate to severe reaction or anaphylactic shock, anaphylactic reaction, don't infuse them colloid solutions. Always infuse them crystalloid solutions. Uh, in the last thing is in situations where there's increased capillary permeability, it can enter the interstitium and can cause problems. So, like in sepsis and ARDS patients. Right. So, what are the different types of colloids or colloid intravenous solutions? We can again subdivide those largely into natural colloids and synthetic colloids, as we mentioned earlier. So, what are examples for natural colloids? So, examples are blood and blood products. So, whole blood, packed cells, so packed red cells, fresh frozen plasma or FFP, platelets, cryoprecipitate, and various albumin solutions are examples for natural colloids. So, then what are examples for synthetic colloids? So, we have gelatin solutions. Now, gelatin solutions are of not much use now. Then you have dextran solutions, then you have hydroxyethyl starch solutions. Examples for gelatin solutions are Himaxel and gelafandine. So, hydroxyethyl starch or heta starch, so it's a synthetic starch where hydroxyethyl ether is introduced into glucose to retard degradation by serum amylase. So, a 6% hydrolyzed amylopectin is available in 0.9% saline, and that final solution is called hydroxyethyl starch. So it has a colloid osmotic pressure of 30 millimeter mercury, so it stays longer in circulation than with albumin, and it is associated with a rise in serum amylase levels. And generally, the maximum dose of infusion of a hydroxyethyl starch is 20 milliliters per kilogram body weight of the patient, and it can affect bleeding time and other coagulation studies as we discussed earlier. Right, so dextrans are also examples for synthetic colloid solutions. Here you have glucose polymers from sugar beets, and there are different preparations of different molecular weights. So there you have dextran 40, you have dextran 70, then you have dextran 110. Dextran 70 is what is most commonly used out of dextrans. And so, what are problems associated with the dextran? So, they can increase bleeding time by inhibiting platelets, they can interfere with cross matching, and they may produce allergic reactions. So, gelatin solutions are also examples for synthetic colloids, not much used now. Himaxil and gelufandine are examples for those products. So, they are produced by hydrolysis of bovine collagen, can cause allergic reactions. And Himaxil also contains calcium and potassium. Then there are different albumin solutions as examples for colloids. Now, some albumin solutions are prepared from donor plasma. Then there are synthetically produced albumin solutions also prepared from genetic engineering. So, albumin 5% and 25% are prepared from donor plasma, and those are heat treated, therefore, there's no risk of viral infection transmissions. And 25% albumin can expand plasma volume by up to about 5 times the volume infused. So, for instance, if 25% albumin 100 milliliters is infused, it can draw water into the intravascular compartment, and that itself will also stay in the intravascular compartment for a longer time, and can increase the uh, volume maybe 4 or 5 times of that, roughly 400 500 milliliters. Then you also have other colloids like 7.5% saline with dextran or hitastat. You don't have to know about these things. Now, let's say what's going to happen if you infuse 1 liter of 5% dextrose into a patient. So, let's say you have inserted an intravenous cannula, you have a drip set, and now you are infusing 1 liter of 5% dextrose. And to remind you how much of water do we have in our body, 60% of our body weight is water, and 60% of 70 kilogram is 42 kilograms. Since density of water is 1, if you have 42 kilograms of water, it will be equal to 42 liters of water also. Out of that 42 liters, we learn that two-thirds or 66% will be inside cells, which is about 28 liters, and 14 liters will be outside cells in extracellular fluid. And out of that also, about 75% is in the interstitial compartment, which finally is about 10.5 liters, and there's about 3.5 liters of water in the intravascular compartment. So once 1 liter of 5% dextrose is metabolized, infused, dextrose or glucose in that solution will get metabolized, and thereafter free water rapidly equilibrates in the extracellular fluid and the intracellular fluid. So let's say you have infused total of 1 liter of 5% dextrose. 66% of it, or two-thirds, will go into the intracellular fluid, which is 660 milliliters. 33%, or one-third, will come to the extracellular fluid, which is 330 milliliters. And out of that, again, there will be, out of this extracellular fluid water, 75% will be going into the interstitial compartment. So 75% of 330 will be roughly 250 milliliters, and only 25% of what has come to the extracellular fluid will be remaining in the intravascular compartment. So it will roughly be 80 milliliters finally staying in the intravascular compartment. Now you see, you have infused 1 liter of 5% dextrose into a person's blood vessels, and finally only 80 milliliters is remaining in the intravascular compartment. Inside blood vessels, rest has gone out to the interstitial compartment, and from there into the intracellular compartment. Right, now let's see what happens if you infuse 1 liter of an isotonic crystalloid, normal saline or Hartmann solution, into the intravascular compartment. Let's say you have a patient who have inserted an IV cannula and you are infusing 1 liter of normal saline. And to recapitulate what we learned earlier, we said 60% of the body weight of the body is due to water. So out of 70 kilograms, 60% is 42 kilograms, and since density of water is 1, 42 kilograms equal to 42 liters, we have 42 liters of water in our body, and out of that 66% is in the intracellular compartment. Therefore 28 liters are in the intracellular compartment and 14 liters are in the extracellular compartment. Out of that 14 liters also, 10.5 liters are in the interstitial compartment and 3.5 liters are in the intravascular compartment. Now when you see different books, different references, you might see slightly different values, but that's okay. Just get the big picture into your head. We have a higher percentage of water in the intracellular compartment and a lesser percentage in the extracellular compartment. And out of that extracellular compartment also, roughly about 75% are in the interstitial compartment and 25% in the intravascular compartment. And if you can remember that, that's fine. Right, so the solution you are infusing now is an isotonic crystalloid like normal saline. Hence the osmolality of that solution is equal to that of extracellular fluid, equal to that of roughly serum. So it distributes only in the extracellular fluid, and it would not enter into intracellular fluid, or it would not change composition in the intracellular fluid. So your total body water, which was earlier 42 liters, now will become 43 liters. Intracellular fluid compartment is not changed, so it was 28 liters and it will remain as 28 liters. And the extracellular fluid compartment will expand by 1 liter, so 14 liters will become 15 liters. And interstitial, out of that extra 1 liter, 75% will go to the interstitial compartment, 25% will go to the intravascular compartment. So 750 milliliters and 250 milliliters. So 10.5 liters plus 750 is 11.25 liters, and 3.5 liters plus 250 milliliters is 3.75 milliliters. So try to get the big picture into your head. Now let's see what will happen if you infuse a liter of a colloid. Let's say you have infused a liter of a dextran or hydroxyethyl starch. So we learned total body water was 42 liters, hence it will become 43 liters. And colloid solutions are going to stay in the intravascular compartment without easily entering the interstitial compartment and not at all the intracellular compartment. Therefore, intracellular fluid volume would not change and it will remain as 28 liters. Extracellular fluid water will increase by 15 liters. However, since this colloid solution has large osmotically active particles which are not easily going to go through the plasma membrane, the vascular membrane, they will remain in the intravascular compartment and they will expand the intravascular fluid by 1 liter, hence 3.5 liters would become 4.5 liters, and interstitial fluid volume would not change. Right, so in a hemorrhage, if you infuse hypotonic crystalloids like 5% dextrose, they would not expand the intravascular volume. If you infuse isotonic crystalloids like a normal saline or Ringer's lactate, they will increase the intravascular volume temporarily, but after 1 hour, only about 25 to 30% will be in the intravascular volume. Rest would have gone to the interstitial compartment. Therefore, if you are to replenish the lost intravascular volume only by isotonic crystalloids, you may have to give about 3 to 4 times of the lost volume. But isotonic crystalloids are good to replenish the interstitial volume. Whereas if you infuse colloids, they will remain in the intravascular compartment and they will expand the intravascular compartment. So you can replace a loss of blood with a one-to-one replacement. So if you have lost 500 meters of blood, you can infuse 500 meters of a colloid and that will expand the intravascular compartment. So colloids should be used to fill the intravascular compartment if the patient has lost a lot of blood, if the patient has had a major hemorrhage, and if you need to expand the intravascular compartment very fast. Right, so last slide of my lecture is on electrolyte balance. So there are three salient things I want you to remember. So one is homeostasis of the body maintains electrolytes and acid bases in a very fine control, in a very fine balance. And this is essential for maintaining electrolyte and acid base status of interior milieu statically for smooth functioning of enzymes, local hormones, and neurotransmitters. And the third thing I want to reiterate is fluids, electrolyte, and acid base status balance. Those things happen together and are joined with each other. The control goes hand in hand. So it's very difficult to separate fluid balance from electrolyte balance or acid base balance. Now all these balances happen together, and an imbalance of fluids would affect an imbalance in electrolytes, and that will also create an imbalance in acid base status. So because all these things are happening in one human, inside one human's body. Now when it comes to electrolyte imbalances, so there are many electrolyte imbalances. For an example, low sodium or hyponatremia, and high sodium hypernatremia, low potassium hypokalemia, high potassium hyperkalemia, low calcium hypocalcemia, high calcium hypercalcemia, hypomagnesemia, hypermagnesemia, hypochloremia, hyperchloremia. So there will be many electrolyte imbalances, but you don't have to learn great details about those things at this stage. You can learn those things with your further training in your dental school career. So we'll stop there. Thank you very much.